Well, I guess good morning or good afternoon, depending on which time zone you're in. I'm Dale McMurchie and part of the Secretariat with Team Primary Care. Before we get started in our upcoming webinar, I'll start with the Indigenous Land Acknowledgement. While we meet virtually, let us begin by acknowledging the ancestral territory of all of the First Nations, Inuit, and Métis people from coast to coast to coast upon which we meet today. We acknowledge the need to work collectively and individually to recognize the past and continued effects of colonialism and racism on Indigenous families, communities, and knowledge systems through the Indian Act, Indian residential schools, Indian hospitals, and other systematically discriminating policies, practices, and documentation. We affirm our responsibility as settlers to improve relationships between nations and actively seek greater understanding of Indigenous people and cultures in the communities in which we live, learn, work, and play. Please join us in this acknowledgement and commitment, each in our own way and through Team Primary Care, to move forward towards truth and reconciliation. So thank you for joining us as part of the webinar series for Team Primary Care. I'm really pleased to have Javeed Sukhera to join us today in a webinar entitled From Hurting to Healing, Restorative Approaches to Advancing Equity. Dr. Javeed Sukhera is the chair of psychiatry at the Institute of Living and the chief of psychiatry at the Hartford Hospital in Hartford, Connecticut. In these roles, Javeed is responsible for advancing the Institute's clinical, research, and educational missions, including training programs in psychiatry, psychology, social work, and nursing, as well as several endowed research centers. He is also an associate clinical professor of psychiatry at the Yale School of Medicine. Javeed is an internationally recognized health professions education researcher and thought leader. His research program explores novel approaches to addressing stigma and bias among health professionals. He has also been involved in advocacy and cross-sectoral work in education, policing, and community services. Javeed is also on the editorial advisory board of the Canadian Medical Association Journal and deputy editor of the journal Perspectives on Medical Education. I'm very pleased to have him with us today. And over to you, Javeed.
Thank you so much for the invitation. Thank you for the opportunity to share space with everybody. Just to start off, can you all hear me and see everything okay? Thumbs up. Great. So I'd like to start by pausing for a moment and acknowledging the space that we're trying to co-create today is in the context of a tremendous amount of hurt and pain that many of us may or may not be experiencing. It's extremely important before we engage in any conversation or dialogue about advancing equity and justice that we honor the complexity and nuance of how we might be feeling as humans emotionally at this moment. I am feeling pretty rough to share with all of you. It's been a very rough time in general, but in particular, over the course of the past 2 weeks, it has had me in knots. I have struggled at times to be able to be fully present because of the pain and suffering and dehumanization and the direct and indirect experiences of trauma that people I know and care about are experiencing. And I'd like to bring that into the room and share that with you, to be very open and vulnerable, because the work that we do, the work that you all do, can't be uncoupled from the humanity that we bring into it. So I'd like to start with an excerpt from a poem by Shire, who said, "Later that night, I held an atlas in my lap, ran my fingers across the whole world and whispered, "Where does it hurt?" It answered, "Everywhere, everywhere, everywhere." So in the context of the world in which we exist, we are here today to talk about restorative approaches to advance equity and justice in the context of your work. I've had the honor of sharing space with a subgroup of you to share some of what we're talking about today. But as I've learned more and more about the extremely important work that you and your teams are doing, I'd like to invite you to pause for a moment and check in with yourself. I'd like you to ask yourself why you're here, why it is that you do the work that you do, why helping to build and integrate and advance primary care at this time in Canada's history is important to you, and why, for you, ensuring that the work is done with the principles and values of equity and justice is part of your mission. I'm going to pause just for a few moments for some quiet reflection as I invite you to ask why you're here. So what I've learned is that your teams are not simply talking in abstract platitudes about these topics, but that you've all been very much engaged in the beautiful yet messy work of implementation. It is a world I know quite well. I have straddled between different hats and roles. But for me, most recently, 2 years ago, I made the decision to move from an identity of being a scholar activist and a physician and a community leader to the opportunity to be someone involved in a structural leadership role in an organization to do that messy work of implementation, which is work that often goes on in the shadows. It's work that, as you and I know, doesn't always come with the same laurels and rewards, but it is the necessary work of moving health systems towards something better that all of us must do. Part of doing the messy yet beautiful work of implementation is understanding how tough and painful it can be at times. So as we think about that, let's pause for a video break.
How many of you are blamers? How many of you, when something goes wrong, the first thing you want to know is whose fault it is? Hi, my name is Brene. I'm a blamer. Let me just tell you this quick story. So this is a couple years ago when I first realized the magnitude to which I blame. I'm in my house. I have on white slacks and a pink sweater set, and I'm drinking a cup of coffee in my kitchen. It's a full cup of coffee. I drop it on the tile floor. It goes into a million pieces, splashes up all over me. And the first, a millisecond after it hit the floor, right out of my mouth is this: "Damn you, Steve." Who is my husband? Because let me tell you how fast this works for me. So Steve plays water polo with a group of friends. And the night before, he went to go play water polo. And I said, "Hey, make sure you come back at 10, because I can never fall asleep until you're home." And he got back at 10:30. And so I went to bed a little bit later than I thought. Ergo, my second cup of coffee that I probably would not be having had he come home when we discussed. Therefore, and so the rest of that story is I'm cleaning up the kitchen. Steve calls, caller ID. I'm like, "Hey." He's like, hey, what's going on, babe? What's going on? So I'll tell you exactly what's going on. I'm cleaning up the coffee that spilled all, like dial tone. Because he knows. How many of you go to that place when something bad happens, the first thing you want to know is whose fault is it? I'd rather it be my fault than no one's fault. Because why? Why? Because it gives us some semblance of control. But here, if you enjoy blaming, this is where you should stick your fingers in your ear and do the na thing, because I'm getting ready to ruin it for you. Because here's what we know from the research. Blame is simply the discharging of discomfort and pain. It has an inverse relationship with accountability. Accountability, by definition, is a vulnerable process. It means me calling you and saying, hey, my feelings were really hurt about this, and talking. It's not blaming. Blaming is simply a way that we discharge anger. People who blame a lot seldom have the tenacity and grit to actually hold people accountable, because we expend all of our energy raging for 15 seconds and figuring out whose fault something is. And blaming is very corrosive in relationships, and it's one of the reasons we miss our opportunities for empathy. Because when something happens and we're hearing a story, we're not really listening. We're in the place where I was, making the connections as quickly as we can about whose fault something was.
So if you're like me, even though I've shown that video many, many times, there's always something to learn from it. And why I believe this is a brilliant video is because, as I said earlier, this messy work of implementation happens for us at a human level. And work that we do around equity and justice has and continues to often be challenging, because a lot of the approaches that we take tend to be framed around this idea that there's a group of us who want to do right, and there's a group that maybe doesn't, and that perhaps our work just needs to round up all the people who might not be on board and train them in a workshop, which we all know is kind of ridiculous. So the early work that I did in this area started by asking ourselves, what happens if, instead of pointing fingers, we actually start the work by looking in the mirror at ourselves and our systems? But what happens when you hold up the mirror to yourself and your system is that you have to reckon with awareness that we can all be part of something that might be harmful, despite our best intentions. And when we do this work together across disciplines, across hierarchy, across different groups, across community, the realization that there may be tensions or that we can be part of harm is very painful. It hurts at our core. It's important to remember that the experiences of identity-based discrimination themselves are a form of harm and trauma. But the work that we do can also leave a residue behind. It can create tension and fear because of our deepest and most vulnerable places of who we are, where we fit in, and where we want to belong. I've experienced these reactions myself many times throughout my work and my career, where I might have said or done something I didn't mean to. I might have elicited a reaction that made me pause and react. And it's something that I think we all have to be attuned to, because it creates a reaction, a form of distress that can affect us viscerally at a physical level through physical reaction, shaking, sweating, insomnia, hyperarousal. It can create emotional reactions through shock, fear, grief, anxiety, disorientation, hypervigilance, sensitization to certain types of cues, irritability, restlessness, rumination, thinking about things over and over, and shame and guilt. Guilt is I did something wrong, but shame, which many of us in healthcare are more prone to experience, is this sense that I am wrong, that I am flawed, or somehow deficient and vulnerable. But in more advanced ways, it can lead to detachment, disconnection, numbing, and going through the motions. And that can lead to behavioral responses like avoidance, isolation, or for some of us, hyperactivation, as that workaholic within us digs in deeper to work twice as hard or 3 times as hard. And then within relationships, how we engage with one another on teams or cross difference in hierarchy can lead to withdrawal. It can lead to avoidance and distancing, and at times it can lead to an unhealthy enmeshment around people we feel comfortable with. So we have to ask ourselves about the cultures in which we live and work, the cultures in which we seek to advance this work in team primary care. Are we creating a culture and a system that my research would suggest is a form of toxic perfectionism, where we consistently add and fill more and more and more in people's cups, expecting us to do more and more and more and be perfect at it? Or are we doing it in a culture where we try to foster progress, compassion, grace, and space, knowing that we can, will, and do mess up, sometimes more than we actually succeed? Research on the topic of racial trauma gives some insight into how these deep wounds manifest themselves. This is a quote from Dr. Resmaa Menakem, who wrote a brilliant book called My Grandmother's Hands, and is a foremost authority on the topic of racial trauma. Dr. Menakem's work looks at identity-based discrimination, the wounds of suffering when it comes to the discrimination trauma, psychological trauma, intergenerational, historical trauma. And this distinction that he describes between 2 forms of pain really resonated for me in my work. He says, clean pain is the pain that mends and can build your capacity for growth. Dirty pain is the pain of avoidance, blame, and denial. When people respond from their most wounded parts, become cruel or violent, or physically or emotionally run away, they experience dirty pain. They also create more of it for themselves and others. I never heard it described this way, but the reason this idea really resonates is because the dirty pain is the pain that draws us in. It's magnetic. It hits us at a neurophysiologic level. It's right now could be the pain of doom scrolling, of constantly, mindlessly looking, searching. It could be the pain of rumination, but it could also fester and get infected and become the pain of resentment and bitterness. Clean pain, in contrast, is the pain of transcendence and growth. And the case here is that for us to do work in equity and justice, we need to spend time with our clean pain while recognizing the draw and allure of that dirty pain. In many communities that experience prejudice and discrimination, dirty pain can become something that actually leads towards reenactment of oppressive cycles, whereas clean pain can become something that's modeled through hope, love, faith, and vulnerability, and then also foster healing, which needs to have our informed consent. Far too often in this work, there is hurt, but at times there can be a tacit investment in hurting, which I would argue needs to shift towards a conscious and mindful investment in healing. During the course of the early days of the COVID pandemic, myself and a team of colleagues were watching pain unfold. We were watching, in particular, the disproportionate impact that pandemic policy was having on some populations compared to others. And we realized that for so many people who work in healthcare leadership, a lot of what we learn is to avoid tension, to shy away from it, And that at a time of crisis or struggle or pain, we tend to sort of hunker down and start to think in very black or white ways. Collaboration in teams, though, as you know, requires a different shift. We co-authored what we described as a framework for inclusive crisis leadership that emphasizes that there are constructive tensions in our work that we need to be willing to lean into if we want to foster healing. The first is the tension when we encounter some sort of challenge, some form of issue or heat or feedback that is destabilizing. It's the tension between wanting to fix something in a moment and between being able to co-create space to name, honor, and spend time with and metabolize some of the feelings and emotions that might be elicited at that moment. The second tension is the tension between looking at a situation in terms of its constituent parts, zooming in to all the bits and pieces, being analytical, and zooming out and seeing it for what it really is. A lot of times when we're doing this work of implementation, we might see something that seems either innocuous or really focused, but that really isn't what's happening if we think about it and step back. Sometimes that situation, that conflict, that tension is really not just about what we're seeing, but about everything else that's happening in terms of the way that power and power asymmetries might unfold. And the third is a very personal tension. It's the tension between ourselves and others. So many of those who are logged on today, like me, are rooted and oriented towards caring and empathy and compassion for others. But we are also primed to have less of that empathy and compassion for ourselves. An essential ingredient in being able to do this work in a restorative way is to actively practice self-compassion, to check in with ourselves and how we're doing, and make sure that we do so while facilitating compassion for each other at the same time. Earlier this year, we published a paper that shed light on how this actually unfolds in organizations. Through my role as a research consultant with the Mental Health Commission of Canada, what we did was a 2-year project where we looked at exemplars nationally that were able to dismantle structural inequities effectively. We started by a call for case studies, exemplar case studies across the country. 62 case studies applied with details about their projects. And then we selected out of those 6 exemplars, examples of places that were doing this work effectively, sustainably. Then we published a report, we interviewed all the exemplars, we did site visits, and that was published last year. But then this year, we took a deeper dive into all of these case studies to run what's called the realist synthesis, where we tried to understand what works when and in which circumstances. What are those ingredients of organizations that can effectively dismantle structural inequity? And what we learned is that even before the work can happen, the work involves groups, teams, individuals that don't always start with agreeing on everything. And they don't always start with a sense of power sharing. They actually start with the power imbalance. But it's of pivotal importance that before the work begins, that there's an identification and articulation of a shared understanding of what is the issue that we're trying to address. There also needs to be a clear and transparent vision for desired change. What would it look like if we were successful? But what was most important wasn't about the specifics of what everyone believed, because of course there was divergence, there was disagreement, but what was explicit at the outset was values alignment, that across diverse partners, there was a clear alignment and concordance of the values that drive the work. Another really important ingredient was shared governance models and shared payment structures, especially when it came to asymmetries in finance and resources. The actual mechanisms of change were about trust. They were about building and sustaining trust, recognizing that mistrust can happen. They were about redistributing power relationships, so actively and intentionally practicing power sharing, especially in contexts where power hoarding tended to be the norm, and actively and consistently measuring and monitoring outcomes in a participatory way throughout. The work was successful when organizations were able to build support and capacity for disruptive change. There had to be not just an embracing of innovation, but an embracing of disruption, knowing that this work is inherently disruptive when you disrupt norms or disrupt existing power structures. It also required organizations to actively anticipate and manage resistance, knowing that there's different forms of resistance, but oftentimes there can be very good faith resistance that's rooted in fear or anxiety that teams and groups need to create space to process and metabolize. That also meant actively and proactively seeking feedback, because feedback is a key ingredient in building and sharing trust, and then embedding these changes into existing structures so that the work is sustainable and lasts long after any particular intervention might be over. So I've shared a little bit more context, but what I want to cover now is pivot into how do we do this? How can we talk and lean and discuss when it comes to some of the tensions in conversations that we might be encountering? To do this in a restorative way requires, like I said, aligning core values. It requires having the embracing of constructive tension being explicitly a value. It requires a restorative focus, which means focusing on healing and growth, preventing conflict by building community and fostering what we would call relational cohesion. A restorative approach recognizes that when harm occurs, it can create wounds and pain that must be attended to. Another value is that this work has to be dialogue focused, and there's often a key difference between dialogue and discussion. While discussion is often agenda driven, it should be complemented by dialogue, which honors emotions and experiences. Dialogue and dialogic forms of learning are intersubjective, and they seek to share authority, whereas discussions can be more cognitive, objective, technical, and hierarchical. Healing requires dialogue. That doesn't mean that there isn't a need and space for discussion as well. And different organizations will look to complement dialogue and discussion in various ways. Another value is to be trauma-informed, and I'll give us a bit of a framework to do that, as well as being non-coercive. And that means inviting participation in the work only through informed consent and not forcing people or making people feel forced to participate. And lastly, it requires attending to cultural, historical, structural, gendered, and colonial factors, and be informed by the principles of an anti-oppressive value, teaching, and mindset. When I talk about constructive tension, what I'm inviting us to do when we experience tension in this work is to be intentional to embrace the power of the pause. It means to literally and figuratively step back from what's happening and pay attention to what's happening around us, what's really happening, that zooming out that I talked about earlier. It requires that we acknowledge our reactions, our judgments, our interpretations, and our inferences about what we think is going on. But it also requires us to be deliberate about taking the perspective of other people in the room and being deliberate about trying to understand other perspectives, thoughts, judgments, or inferences, especially those that might be divergent from our own. To embrace the power of the pause is not to react, but to search for a path forward that affirms, uplifts, and dignifies everyone involved. not to fall into a coercive cycle where we respond to our feelings of powerlessness by trying to take control or power instead. And it requires us to act, to not just be analytical and process, but to actually move forward and do something. I would make the case that this work requires that we're deliberate about disrupting dichotomization. Us versus them, binary, dichotomized thinking can become commonplace when encountering tension if we let it. Like was illustrated in the video that I shared earlier, this is the path of least resistance. And we all, myself included, do this all the time. We as individuals often dichotomize ourselves in relation to organizations, communities, or society at large. But if we want to disrupt this cycle, we have to stop and recognize that two things can exist at the same time. Yes, we can be part of an organization, team, or community, but we are also part of making change in that organization, team, and community. Yes, we can look to people with other forms of power, especially structural power, to make change, but we cannot absolve ourselves of the power and control we have to make change within our worlds and realms of influence. I want to touch briefly upon a framework that we co-designed with students in various professions, as well as individuals with lived experience of discrimination in the health system. This framework is available online, free and open access for anybody who wants to take a look. The website is sharedhumanity.ca. And if you visit the page and you click on the Health Professions tab, it actually works through cases and examples on how to enact this framework. And it's built on three pillars. The first is shared trust. The second is shared power. And the third is shared humanity. Shared trust requires being explicit about recognizing what builds and erodes trust when it comes to relational work. And it means actively fostering trust through dialogue. Sharing trust requires intention. It requires humility and deference to each other, but it also requires honesty and the cultivation of feedback on a regular basis. It requires normalizing feedback as something that makes things better and shifting mindsets away from the idea that when we hear feedback, we should think what's wrong with us, and towards knowing that when we hear feedback, we should think about how we can be better. But the honesty part really needs to be foregrounded because we can't always do everything. We can't always fix everything. We have to be honest about what we can and can't do in a moment, rather than pretend like we can take it all on. And sometimes honesty requires radical transparency and boundaries about what is or isn't possible within a moment. It's about embracing the idea that the kindest thing we can do in some of these moments of tension is be honest with ourselves and each other. Sharing power is about reducing and reconciling power differentials because they will continue to exist. It requires increasing knowledge about how power is understood and perceived, sensitizing to us how we are perceived in particular. And it means fostering shared decision-making. It also means acknowledging irremediable differences without being distracted by them. And I think this is really important when it comes to work in interprofessional teams. There is a dominance of a medical kind of way of thinking that at times can be very disruptive and asymmetrical. But at times it also is and continues to be the reality of the way that medical, legal, regulatory systems align. Yes, we need to work to dismantle some of that. But in the meantime, we can't and shouldn't be too distracted by those power differentials as we name them and work to mitigate their harmful effects. Sharing power also requires acknowledging that there's different forms of power. Yes, there is structural power and positional power that we often think of, but there's also power to reward or punish. There's the power of knowledge. There's the power of expertise, which is a form of knowledge in itself. And the power of experience, lived and living experience, needs to be honored as well. Regardless of our positionality and structural power, We all have the power of influence, power to shape and role model change. And the third pillar is about sharing our humanity. It's about finding ways to bring our most authentic and human self into the work that we do in a way that feels okay to us. It doesn't mean oversharing. It doesn't mean centering ourselves, especially when there are and will be more vulnerable folks out there. But I think of sharing humanity as decentering ourselves in the work without dehumanizing ourselves. It requires the ability to engage in strategic self-disclosure, being able to do a little of what I did earlier, acknowledging that I might not be doing the greatest, but not overburdening anyone with specific details of what I may or may not be experiencing. But shared humanity also requires actively practicing self-compassion, recognizing that we live and work in a world that often pushes us towards self-doubt and self-blame. Shared humanity requires attending to vicarious forms of trauma, and it requires being attuned to differences in self-expression. Not everyone is going to disclose everything, and each and every one of us should get to choose and be authors of our own story. We have to be attuned to those differences without projecting our fears and anxieties onto one another. This idea of strategic self-disclosure requires that we be, like I said, authors of our own story. Why are we here? Question I invited you to reflect on earlier. We have to humble ourselves to others, knowing that they're experts in themselves. We have to be genuine and honest, but we also have to respect boundaries and share only as much as is appropriate in order to foster trust and enhance a sense of agency and choice. As I said earlier, this work requires active self-compassion, active self-forgiveness, active self-validation, and self-kindness to consistently seek ways to fill our cup so that we're not coming or functioning from the red zone when we approach this work that can be quite cognitively and emotionally draining. So the shared humanity framework, as I mentioned, is available. This QR code leads directly to a set of articles that I referenced today. And when I think of the messy work of implementation and take-home ideas or messages, to me, other than the idea of sharing humanity, sharing power, and sharing trust, it really is about three simple things. It's about enhancing agency and choice. It's about role modeling vulnerability. And it's about recognizing that at times that feel uncertain or scary, that the best path forward is to co-design change together, working hand in hand towards what might feel like an uncertain future. So with that, I'm going to pause for a few moments, just give everybody a mental, cognitive, emotional break. Check in with yourselves and each other. And then what I'd like to do is to read a case to get some discussion going about how we could approach it, but also to use the case simply to elicit that discussion and invite all of you to bring some of that messiness, some of those tensions, some of your own experiences into the space. Now, this session is being recorded, so I think we have to be mindful of that. We have to balance the desire to share and spread some of the messages and learning from today with the opportunity to create a brave space. But with that stated, I still believe we can have a rich and fulsome discussion. I'm going to read the case briefly, then take down the slides, and then invite some facilitated discussion. So I'd like to consider the example of a conversation amongst an interdisciplinary team about a Black patient admitted to an inpatient unit. A member of the group that has leadership or administrative position within the hierarchy states that Black patients might perceive well-intended actions as discriminatory. But during the session, a member of the group shares that they are offended by the idea that white people are all racists. Now, this is a case that I've used consistently in teaching and discussion, and it's a case that allows us to lean into how we deal with some of the emotions, resistance, and tension that these conversations can elicit. So I'll stop sharing my screen can open it up, and I'll look to Dale to facilitate some conversation.
Sure. Thank you, Javeed. Has anybody got a comment on or some reflection on this case study? You can put your hand up in the chat. One of the things that occurs to me is that the particular individual that made the comment may well have some of their own self-doubt and perhaps some niggling questions themselves around equity, diversity, and inclusion with patients. Ranjit, you're on mute, so please share your thoughts.
Hello. Yes, thank you so much for this enlightening discussion. I think it's very thought-provoking, and your case there, I think, is it's very layered. My initial reaction to that case was very layered. It's a very layered case. On the first instance, the patient, the Black person, perceives probably unconscious bias as a discrimination in its discriminatory form, and that's a cause of obvious concern to him. And yet the response from the white group who were, I assume, providing care for him is defensive, and perhaps with the belief that they are tolerant, yet don't recognize, tolerant of discrimination, and not overt racism, but covert, implicit racism, and tolerant. Their tolerance extends so far that they are unaware of their potential for unconscious bias in this case. And the issue I have is then, how do we, and I think this is the pertinent question here, how do we engage that individual who feels defensive without, in a thoughtful process, so that they can be more consciously aware and not at the risk of alienation or a threat to their perceived position of privilege. That's, I think, is that's the pertinent question here, I think.
Thank you. Thank you for sharing that. Ivy, your thoughts.
Thanks so much, Dale, and thank you so much, Javeed. I'm thinking about this case and maybe extrapolating, and I'm wondering, Javeed, both the patient as well as the healthcare providers, we're all on our own journeys, and because of that, it's really challenging. So the reactiveness or the defensiveness may actually be because of the place where one is on the journey, either being the patient or being the provider. And I think what you said originally about compassion, and not jumping to blame, and not jumping to conclusions, and not and reacting. I am wondering if that's where we go with this. Is that one could blame, one could actually be really angry, one could react, or one could step back and be compassionate and ask the question. I wonder where that person is on their journey. I wonder how, and knowing that if you're ahead of the journey, right, that you were once there, and so there is a pause, as you said. So I guess that would be my thoughts about going back to your original, and how we as Team Primary Care are trying to embed compassion and values in the type of learning that we want to offer primary care providers, and the type of care we want to provide in the primary care context. So just some thoughts on that.
Thank you, Ivy. Javeed, did you want to respond to the first two sets of questions before we go to Carlene, or should we?
Yeah, so I see Carlene. So Carlene, I'll just quickly respond and then really interested in hearing your thoughts. So I gave a lot of different examples of how we can respond, right? I do think that the first thing to do is that power of the pause, right? Let's step back. How am I reacting? How is this making me feel? How do I view this? What's the frame? Well, what are the other possible frames that might exist that aren't the same as me? And how can we move forward in a way that again uplifts and dignifies? So I do think that there are and continue to be a natural kickback and defensive response that happens. That at a neurobiological level happens because of the way that power affects the brain. So anybody in any society of any identity, when they experience a sense of power, that can at times be intoxicating, right? And hearing something that infers or suggests that our view of ourselves is somehow discordant with someone else can be very destabilizing and threatening. Any of us who've received feedback can relate to that. So the way that I describe it is, yes, we share trust, we share power, we share humanity. That's a whole other workshop we can do. But in a very distilled sense, it is about holding our power in one hand and holding our vulnerability in the other, and allowing them to coexist in that moment. Now, we tend not to see our own power, not sensitized to it, right? We see power that other people have. But what we should be doing a better job of is looking in the mirror and recognizing the power we might have in that situation and how people might project all sorts of fear, anxiety in space. We should validate that people will and do feel defensive and feel tension, while at the same time creating space for a conversation that, again, has informed consent, isn't coercive, but is anchored to a set of common values. That doesn't mean that if we encounter what I would call forms of bad faith resistance, that we need to spend time with those. Bad faith resistance sadly also exists in society. It exists through the politicization of compassion. It exists through the explicit advocacy against equity and dignity for some populations. And that's simple. If I encounter bad faith or resistance in my organization, for example, someone who's explicitly transphobic, we have a clear and candid conversation that doesn't align with the values of our work. And that's very different from, I care, I want, but I'm afraid, or I'm tense, or I'm struggling. And that is something we want to try to create space for.
Thanks, Javeed. Carlene.
Sometimes the mouse doesn't want to react. Thank you so much, Javeed, and thank you for all the comments that were brought forward. When I look at your model, and it's very helpful to see it in a graphic way, that we're sharing this space, we're allowing ourselves to become vulnerable, we're noticing, realizing both the power and the vulnerability that we all hold, but then wanting to be brave. That's where I always have to really pause and think carefully, because if one of the things we value is transparency, and we are valuing just putting our cards out there on the table, the good, the bad, and the ugly, and that this is a safe space to share our fears, it's a safe space, no one is going to be criticized or belittled, no matter how different their thoughts and their values might be, or their perceptions might be. I'm wondering, how do I call somebody in versus calling them out when what they share is whatever point they are in the journey of learning, and that point isn't where they need to be by the end of the journey? How do I engage them? What kind of words? And I guess I'm looking for a script of, do I just come out and say, it sounds like you're very uncomfortable. Can we continue talking about this discomfort and figure out where it's coming from? I don't want to say that they're afraid. They may become very defensive, but how do I call them in rather than calling them out?
So thank you so much for asking what's a brave question, right? Because I think we all know that feeling, that fear, that tension. I'm a child and adolescent psychiatrist, and with what's been happening with the world right now, I've been doing a lot of community events, how to talk to kids about trauma and conflict. And ironically, I'd say it's a similar framework. So again, I like threes. It makes things simpler. When we're faced with a situation where we feel that tension and we feel like our silence is important to break, that we need to say and do something, the first thing we need to do is start with ourselves, recognize our positionality and vulnerability. And with this, I think, comes with recognition that the way that conversations and emotions are enacted are fundamentally racialized and gendered. Some of us can say the same exact thing, but also face censure or sanction or punishment for doing so because of the way that this gets enacted. So starting with self means tuning into ourselves, feeling safe enough to do something that feels brave, recognizing our positionality, and recognizing that people might be projecting things onto us, but that we want to project them to project their hopes and aspirations. So starting with self, the next is actually letting them lead. So when another party says or does something that is difficult or technically tricky for us, we can't force ourselves into that space necessarily. We can share observations or reflections, but it has to be a process of healing that they have informed consent with, and that's mapped and aligns with their whatever developmental stage that they might be at for their journey. And the third is to model hope, faith, and vulnerability. It is to focus on not the changing of the other, which we all know ultimately is impossible, and to focus on sharing at a bare default. We cannot get in trouble by sharing how we navigate that tension or how we might approach or feel about that experience or that comment. And it's modeling it in a way that orients towards healing, hope, and change, rather than really, we can name the hurt, right? It's that dialectic. We talk about truth and reconciliation. They go hand in hand. We can name it, we can speak it, but to model it, not just by doing something in a script, but by being that sort of role model of unconditional empathy, that in of itself is a very powerful form of influence in that type of moment of tension.
Thank you, Javeed. Just on following up on that, how do we role model some of the discussion that comes out of hurt or harm or missteps as it relates to acknowledging intention, but also addressing the harm caused or the effects of a discrimination or otherwise?
So there will always be harm and hurt. That's part of healing, right? Like that's an intrinsic process. So in terms of role modeling it, I think it's framing it around starting that we're all striving to be as good as we can. We're striving with these intentions towards moving things in the same direction, but balancing that with accepting the fact that we are going to suck and not being neutralized or hijacked by that fear of maybe not being perfect at it, right? It's that tension between progress and perfection. It also requires, though, in terms of implementation, folks that are involved in work who have leadership roles, who have structural power and authority of being ultimately accountable for finding space and time to do more of the discussion-focused work, which is, not just the processing, but also what are the tangible steps that we can take? How can we create space to co-design what that next direction is? But also then take accountability for outcomes and actions. When I said earlier, pause includes search for an empowering solution and execute the plan, it means that we have to do something as well. So we can say, this is the way this might be happening. This is how we might understand it. How do people feel about what we want to do about this, oriented towards the direction that the work needs to go.
Thank you. Does anyone else have any questions or comments?
I'll put
Maybe
my
just-
email address in the chat if anybody
see.
feels like they.
Jazz has a question. Hi, Jazz.
Hi, yeah, sorry, just to get myself off mute there. Javeed, I think one of the things that's curious to me is, you know, the frenetic pace of healthcare right now in terms of, you know, capacity issues. You know, in our country, certainly we see, you know, and not just the emergency of the hospital sector, but in the primary care sector is under a lot of stress to see people and engage and all of that. And you know, there's a number of solutions to looking at that. But how do you deal with these types of issues? Because you really need to have the time to do this, right? To do it in a thoughtful manner, to do it in a structured manner, and it needs to be almost part of your everyday functioning. And you know, I'm just curious, like how, if you're working with primary care providers or others, you know, where does the time come from for this? And I know, you know, I don't mean that, you know, it has to be set aside because it really should be part of what you do, but there's a learning component. There's a process that you need to go through to do that. And then there's sort of the everyday activity and embedding that in there. So I'm not saying it's additional time, but it's sort of focus and time together, if that makes sense.
Absolutely. I think it's an important caveat because both in the US and Canada, we're not adequately resourcing the kind of care and work that there's a clear return on investment on, right? So to me, this is actually an issue of structural underfunding and structural inequity that we can speak up about, that we can advocate around, but that we shouldn't be hijacked by at the same time, right? You're right, to do this work, we need to be able to have resources, we need to have time, we need to have emotional and cognitive energy, which is difficult to do when sometimes we're working 2, 3, 4 times, 5 times harder than we should. But the structural underpinnings of that are a form of inequity then, right? So, for example, if we have payment systems that incentivize certain forms of care versus disincentivizing the kinds of things we're talking about, then obviously those organizational determinants are going to inhibit our chance for change. Those structural underpinnings, the resources that we invest in what we do, have to be a fundamental part of the change. That doesn't mean we're going to achieve that today or tomorrow. We all know we're not, right? So then it becomes a question of engaging with teams and understanding what we can do, what is possible, what isn't possible. Really being patient and person-centered, having compassion for self and others. That's not necessarily a time burden, but as a leader, I know that I need to have transparent workload for my teams. We need to engage people in annual conversations about how they're feeling about what they're asked to do. If we want to create and co-create an organization where our resources align with that mission of making change. We're doing annual reviews right now, and we've changed our whole process to actually lean into people's perceptions of their workload on a regular basis to make sure that everyone's kind of resourced and supported in a way that's meaningful for them. So it does still require that intentionality, even when we work towards resource changes.
Thank you so much, Javeed, and so much food for thought. I think we would have been happy to have another hour with you. So I really appreciate your time. And just to remind people, this is a second presentation I've seen of Javeed's, and I learn something every time. And so we're recording this. So if you feel like you've missed a nugget, then please, we'll have it again recorded. Many thanks. And just a reminder, as you pop off, there will be a survey. So please complete that for us. Thank you so much. And have a great afternoon, everyone. And thank you. Much appreciated. Food for thought for everyone.